My name is Jody Gutkin, and I will be your presenter today for our topic of foot and ankle orthopedic disorders. There are course notes that follow along with my PowerPoint slides. Those are available to you as a course notes package, minus the images because of copyright. You can access those course notes by going back to our website, cheapceus.com. Scroll down to our topic for today and go to the right. You'll be able to access the link to that course notes packet. You want to either print them out or save them electronically to follow along during the presentation. Our topic today is foot and ankle orthopedic disorders. My name is Jody Gutkin, and I will be your presenter. I have been a physical therapist for over 30 years and also enjoyed being involved in physical therapy education for over 20, and I look forward to discussing this topic with you today. Our course, Foot and Ankle Orthopedic Disorders, is going to examine those different diagnoses of that most distal portion of that lower extremity chain. We will specifically examine pathologies that affect the bones, the ligaments, the cartilaginous structures within the joints of the foot and ankle. We'll take a look at the current research to understand the differences between these specific conditions. The rationale for the course is to really do a comparative analysis of these pathologies so that as you are working with your patients, you can hone in on your interventions to be specific to the pathology that they're presenting with to maximize their outcomes. And we will discuss the trends that we are seeing in the research related to identifying and distinguishing these different conditions for each other, as well as those that may occur concurrently in order to look at our patients who may not be progressing the way we anticipate to see if they need their referral back to the physician for additional assessment. Our goals and objectives are aligned. In order for us to accomplish this, we'll look specifically at the tissues and structures involved in each condition, how we can do different provocative tests and assessments to gain more information about those conditions. And while we specifically don't discuss protocols for each condition, by understanding the mechanism of injury and the tissues involved, we'll look at specific activities, exercises, stretches, components of our rehab programs to either include or avoid until later on in rehab so that we can really be specific in the development of our programs for patients with these different foot and ankle pathologies. As with any course that you attend, when you go back into the clinic to apply this information, you are going to do so in accordance with the federal, state, and professional regulations where you're practicing, and no conflict of interest exists for the presenter or the provider of this course. As we work our way through the presentation, you will notice that several slides on the bottom right corner have this gold icon that says consider this. That's so you know that those particular slides will be of assistance when you're going to answer those course post-test questions later on today. And here we go with our topic. First, of course, we need to start just generally speaking about the foot and ankle and revisiting some of that anatomy that we are focusing on today. We know that the foot is the first thing to hit the ground. It provides that stability, that base of support, as well as shock absorption as we perform locomotion, balance, different weight bearing activities for function as well as recreation. And obviously, we're going to consider our patients that we're already seeing with the different pathologies that we will be discussing today. We also want to consider that many of these conditions can occur in our pediatric, adult, as well as elderly population. We see them occurring across the lifespan, especially when we talk about the different mechanisms of injury. We also want to consider the different populations where we should be looking all the way down to that foot and ankle complex, even if the individual's not presenting with a specific diagnosis in that region. We want to make sure that there isn't something that can additionally be addressed. Consider those patients who have a history of falls, those who are performing gait with any types of compensations because of an injury or a diagnosis elsewhere in that lower extremity chain, the knee, the hip, even the back or the trunk. We know because of compensations that may affect that foot and ankle region. So that brings us to another population that we should really be considering assessing foot and ankle pathology when we're looking at gait and balance. And if the patient, even to ask if they have any discomfort or challenges in that foot and ankle, are those individuals with the different neurologic diagnoses. Someone who has had a CVA who doesn't have appropriate foot placement with gait could sustain an ankle sprain, and they may or may not have the cognitive ability or the sensory ability to recognize that and relate it. So we might need to be aware to look down all the way, just as one example. Because a lot of these conditions, orthopedic and neurologic and other regions of the body, cause either overuse, repetitive use type injuries in that foot and ankle, or potentially trauma as the individual is working through their different activities. Also consider across the lifespan individuals who have changes in their recreation participation, even in their jobs, if they're going from more of a desk job to more of a manual labor type job that we sometimes see as we have those unfortunate shifts in our economy. Consider ergonomic screening and assessments, workplace assessments for individuals where they have had an increase in their activity that may put demands on that foot and ankle that weren't there before, that put them at risk of injury or overuse, cumulative trauma. Looking at the regions of our foot to kind of dust those cobwebs off if this is not a population that you are working with frequently. As we go through our foot, we have several different regions. We have our hind foot, our midfoot, and then our forefoot region. That hind foot is looking at the region of the talocrural joint, which is our ankle joint between our talus and our tibia and then our fibula, and then our subtalar joint here between our calcaneus and our talus. That is going to end right about here on our diagram at our transverse tarsal joint, also referred to as our Chopart joint. And then next we have our midfoot region, which is going to come down to our tarsal metatarsal joint, also referred to as the Lisfranc joint. And that midfoot region is going to encompass our navicular, our cuneiforms, as well as our cuboid on that lateral side of the foot. And there's a lot of movement that occurs in these joints. And I like to bring this up right in the beginning. We don't want to forget about this midfoot. While we don't have specific motions like we think of with the dorsiplantar flexion, inversion, eversion, or overall pronation supination of the foot, there is a lot of gliding movement that occurs in that midfoot. So whenever someone has a pathology where they either have not been moving their foot because of pain or restrictions in different regions, or they've been immobilized for a period of time, we do need to make sure that we look at those midfoot joints as well as the forefoot joints to ensure that mobility is restored to them so that overall the arches of the foot and the different lever systems are functioning the way they should. And then our last region of the foot is this forefoot region, which is going to be our our metatarsals, our phalanges in that forefoot. In terms of muscles, believe it or not, some things have changed. That is part of the fun of being in a career for many decades, we'll say, and some of you out there are with me, and many of you will be before you know it, that they actually do discover new muscles as time goes on, as technology improves and they're in there to see more. So we know that along that lateral complex of the lower extremity, so this lateral compartment region, we know that we have our peroneal muscles that are important for eversion and dorsiflexion stabilization articulation of the foot, peroneus longus, peroneus brevis, and then the peroneus tertius that we're already familiar with. And all those tendons are going to come down around this lateral malleolus region to then either the fifth metatarsal or underneath more into the plantar surface of the foot. That's the anatomy that we're already familiar with. But what they have discovered is there are two more peroneal muscles. So our peroneus quatrus, they're originating kind of either off the muscle bellies of the peroneals we're already familiar with or the fibula itself. And then that tendon is also going to come down and attach into that either calcaneus or that extensor digitorum. And then the peroneus quintus, meaning five, that's coming down onto that aspect of the fifth metatarsal. This might explain why some patients are more likely to develop pathology in this region, those extra tendons coming through that there would be no way for us to know that they are present there, can create an overstuffing. And then when we have excess tendons in that region, overload of any of that requirements for eversion control and stability of the foot and ankle, any little bit of increase in the cross-sectional area of those tendons, any swelling that may occur in that region could cause overstuffing. There could be subluxation of the tendons. There could be other pathology that develops. So I just thought this was interesting to bring up, that if you do have that patient with those peroneal pathologies where nothing is working and they're just not rehabbing the way that you think, and you've kind of exhausted all your options, then referring that patient back to the physician, there might need to be more imaging or something else that occurs. Possibly this rare case that does have those extra tendons. They're estimating that somewhere between 18 and 34% of individuals have that peroneus quintus, and then somewhere between 10 and 20% of individuals do have that peroneus quatrus. So that might account for some of what we're seeing. And then those individuals might need surgical management if our conservative measures are not successful. Arthrokinematics, we already know the basics of our ankle joint, that we are going to have our dorsi and plantar flexion that's occurring. If we look specifically at this surface of our talus here, that talus we know, let's see, this is a little bit better. Look at this one. That talus, it's sitting kind of like a backwards saddle where that anterior portion is wider. So when the individual goes down into that plantar flexion and that wider portion is outside of that ankle mortise, well, now they're more likely to have that inversion type of injury because more movement is permitted. When we look at individuals across the lifespan, and what happens with the gait cycle, we know the normal gait cycle as an individual goes through this, they are going to have their heel strike, go into the foot flat, and then the tibia will translate across the talus, moving into that push off phase of gait. What they're finding as they study individuals who are elderly and they look at force plate analysis is this process is not always occurring. And this will apply to many of your patients. It seems to be part of normal aging. Again, it can account for why we may see more foot and ankle pathology in our elderly population, and reminds us again why we might want to look down at that foot and ankle for our older populations who have any compromise to their balance or their gait cycle. So our young girl on the right hand side here, as we look at her in the gait cycle, this right foot is clearly in our mid stance, and then the left foot here appropriately is moving towards that push off phase of gait to propel her forward. If we look at our older individual on the left-hand image, what we're noticing is her weight is clearly still back here on this foot. And look, I mean, besides not having any base of support, she is clearly back here in maybe mid stance. And we're already in mid stance here almost on the front leg, except the weight hasn't shifted yet. So, what's going to need to occur here is, instead of that back leg that should normally be propelling the individual forward through the gait cycle, they actually need to do a lifting up of that back leg in order to pull through the gait cycle. And that's where we're seeing more of a pull off versus a push off of the gait. The question becomes, well, why does this happen over aging? We do have some natural dropping of the arch, loss of the extensibility of the gastrocsoleus complex. But again, this gives us opportunities that we might be able to see improvements here, because we know all of this is going to compromise shock absorption. It's going to make those forces transmit further up the chain that may lead to other pathology or exacerbate it. Maybe we do have an opportunity to look at gaining more excursion of that gastrocsoleus complex so that we can get more translation of that tibia. Is there range of the first metatarsal for push off phase? What is happening with the arch? Maybe some type of orthotic would be beneficial to restore the arch to give us that rigid lever for push off. So again, opportunities to look further down the chain here. One of the assessments that we're performing on our patients with foot and ankle pathology is assessing the excursion of that gastrocsoleus complex, and our weight bearing lunge test is the most common way of doing that in a weight bearing position that will simulate sit to stand ascending stairs when we need to have that knee flexion in a weight bearing position. So this can be done in standing, or should be done in standing. For that weight bearing position, we're going to have our patients start with their toes up against or slightly away from the wall, and you would measure with the tape measure that distance from the great toe to the wall. They are going to lean forward into that lunge position, keeping the heel flat on the floor to assess that excursion, and they're working on getting that knee to the wall. And you can measure that distance. We can also, in addition to using the tape measure, we can use a goniometer on that opposite side of the ankle, on that lateral side, to measure that dorsiflexion. What they're finding in the research is that there is really good intertester reliability utilizing the tape measure as well as the goniometer. It's almost perfect. Other options of how to measure this excursion would be to use an inclinometer, placing it here on that anterior tibia region. And then same thing with the smartphone on that anterior tibia region if you're using an app. What they find with those two methods of assessment is that there is substantial intertester reliability. The key is, however you're measuring this, is to be consistent in the method of assessment. As the patient's performing this, and we look at, well, what is limiting their ability to go into that dorsiflexion, which is so necessary in these different weight bearing postures, not only for gait, sit to stand, stairs, other functional activities and work activities. Well, what is limiting them? Often, if the individual is complaining of a discomfort anteriorly, that might be some type of anterior ankle impingement that we will be discussing, some soft tissue or osseous structure that is encroaching there, could be capsular. If more of the discomfort is posteriorly, that's more likely to be muscular in origin for that individual. And as we talk about different soft tissues, this is an opportunity to just bring to light some of the changes that have occurred over time in soft tissue management that applies to many of the pathologies we'll discuss today, as well as many of them that you're seeing clinically. We've switched away from just treating with ice in that acute phase, moving towards rice, price, police. I have lived through all of these. And now we are at peace and love as our continuum of care after that initial soft tissue injury. And the thought that we now know, and the peace and love mnemonic, I just was, when I was using it this week with an individual who was much younger, to try and get through that, just because maybe the internet populated ice is the best option to start with an acute injury. Peace and love helped me get through the mnemonic, to give a better explanation of our current understanding of tissue healing. That yes, initially in those first few days after injury, we do need to be cautious with those tissues that were damaged, those ligaments, those tendons, and we do want to protect those structures. Protection means that we are not trying to apply loads that will aggravate them. We're not stressing them in that way. We want to elevate to let gravity allow that reabsorption of the edema that's naturally occurring as part of the inflammatory process where the body is trying to heal itself. That's our preference, our first choice. That's why we are avoiding anti inflammatories, because while they may help with the pain, everyone says that it makes them feel better. Yes, but it's not allowing the individual's body, as we know, to go through that natural healing process, which is what we want to encourage. Compression will help control that edema, that controls the pressure and the pain, the hematoma, and educating on all of this. So those are those first few days. What we do not see here is ice because it counteracts that body's natural healing ability. Then we're going to move into that love phase where we're going to optimally load those tissues. We want to have early movement, early controlled, pain-free mobilization and movement in order to stress the healing tissues in the appropriate way. So as those different collagen fibers are lying down and repairing and remodeling is happening, it's happening in the way that it needs to allow for motion. And we'll talk a lot today specifically with the foot and ankle, allow and enhance proprioception because that is lost quickly and is necessary to restore for improved function and to decrease the risk of re-injury. Vascularization, bringing all those chemical mediators and those cells into the area. So cardio, also for cardiovascular fitness during this more protective healing phase of our exercise. And then the focus is also on optimism. And this is where this model also differs from previous models, that it's going to bring in the psychosocial contributors of healing. It's going to bring in that mental health component also to give someone something else to do for mobility while they are healing. And as we already do, allow them to be an active partner in this planning process and rehab process. What we just discussed applies to many of the conditions that we'll go over today. And now we're going to specifically look at several diagnoses, starting with ankle sprain. Ankle sprain, we know, can occur from different mechanisms of injury. It can be lateral, medial, or a high ankle sprain. And also, other concurrent injuries can occur that we will take a look at that may not evidence themselves until a little further down in the healing process. There are several different ways that ankle sprains are classified. We know our grading 1, 2, 3 that are utilized looking at just the anatomic structures. So as we look at a grade 1 sprain of the ankle. This is going to be a portion of the ligaments that are damaged that are going to cause a little bit of instability. But as we progress to a grade 3 ankle sprain, then we're going to be seeing more tearing of multiple ligaments in the region that lead to a complete instability of that ankle joint. That's just looking at the ligaments themselves. Another way to look at the classification of ankle sprains is based on the pathophysiologic aspect, where initially there might just be that overstretching of the ligaments versus a grade 2, where we have tearing of some of those fibers. We really look at that. In terms of kind of like a rope fraying versus a grade 3, where there is going to be more of a complete disruption of those physiologic components. And then in terms of clinical presentation, we know that individual with the grade 1, they will be able to do some weight bearing on that ankle. It might be painful versus someone who has that grade 3 with that complete loss of stabilization, that individual is going to be unable to stand or weight bear on that ankle. That's just a brief reminder of how we do different classifications of our ankle sprain based on the ligaments involved. And now what we're going to do is take a more specific look at each type of ankle sprain and how that individual presents clinically. Our ankle ligaments, as we look at the different complexes, stay with me. This is not meant to be a nightmare slide from school. And as I go back over this information for courses, I just shake my head at myself and say, why did I feel like I spent like 30 hours memorizing this way back in school when now it seems so simple? But I guess that comes with experience, right? We're all there. The lateral ligamentous complex that we are looking at, that is being aware on this, the ligaments that are coming off this fibula that are going to come down. We have our anterior talofibular ligament, so it just comes from the fibula down to the talus. Then we have the fibula down to the next bone, to the calcaneus, and then we have the posterior going from the fibula to the talus again. So much simpler. As we look at the orientation of the fibers, that anterior talofibular ligament is going to limit that anterior, by being located here, it's going to limit that anterior translation. The calcaneofibular ligament, those fibers are almost vertical. So because those fibers are almost vertical, it's rare that you're going to have an isolated injury in that area. And then the posterior talofibular ligament is usually the last one that is injured. Normally, we're going to see the anterior talofibular ligament, and then because a couple of those fibers of the calcaneofibular slide over and connect in, that could be a secondary one that is injured in that same incident. The deltoid ligament, though, that is going to be our large ligamentous complex on the medial aspect of that ankle. And we are going to have those ligaments that are coming down, going from that tibia, coming down to all the bones, to the navicular, to the calcaneus, and to the talus in that area. And then lastly, we do have our ligaments that make up our syndesmosis. Our syndesmosis is this articulation between the tibia and the fibula and the talus that are going to prevent that diastasis, or that separating of that tibia and fibula with movement, as we have so much ground reaction force coming through. Lateral ankle sprain, our first pathology. Specifically, as we were discussing, the orientation of the fibers plays a role in the pathology and the development of the injury. Historically, what we think of is this individual who is wearing those high heels, where that talar surface is outside of the ankle mortise. They have a misplacement of the foot, or an inappropriate land from a jump or stepping off of a step, where we have that excessive force moving the foot into inversion, damaging that lateral ligamentous complex. Usually, that anterior talofibular ligament is the one that is injured because it is the least extensible and the way the forces are generated. Next would be that calcaneofibular because of its orientation with the vertical fibers and sharing some with that anterior talofib. And then least likely is that posterior talofibular ligament. It would be a much severe sprain. There has been more research looking at the actual mechanism of injury, and this directly relates to enhancing your rehab for these individuals. That a stumble over the foot is also an incident where the individual can fall in this position that leads to that ankle inversion sprain. What they've looked at are athletes, and there was a large study that looked at the videos of different sports and athletes as they were experiencing the injury. And what they found is it's not always, landing in that plantar flexed position with the eversion force. They actually found that for many of the individuals, when they come and they land, we do heel strike. Let's say they're running in football, heel strike to foot flat. Well, during that, milliseconds, of that transition, that's where they're finding instability, particularly of the peroneal muscles at that point in time, are when most of the ankle sprains are occurring. It's not hitting in a plantar flex position so much. It's more not having the stability initially of the foot and then the body weight falling over on top of it. So they're finding that that is a critical time. What that means for us in rehab is looking at the quality of our patient's balance. So maybe consider, rather than looking more grossly as you're doing your different balance challenges for your patient, or the BAPS board or the rocker board in sitting, whatever it may be, look at initially how quickly are they able to stabilize. Look at, with single limb stance, how many lifts they have of the foot versus are they just able to hold that position. Because what they're finding in the research is that initial ability, that timing of the peroneal specifically, and that proprioceptive awareness of when it needs to kick in is very important to help avoid injury. So that can enhance our rehab outcomes. The clinical presentation for that individual with the lateral ankle sprain, we're going to see, based on the severity of the sprain, the ecchymosis on that lateral ankle complex. When we come in to palpate those anterior talofibular, calcaneofibular ligaments, we're going to be feeling that point tenderness for the individual, looking at passive movement of inversion, plantar flexion that stresses those ligaments will be tender. We also want to come all the way up the lateral compartment and palpate into those peroneal muscles that may be overstretched to assess their integrity. And then also, because we're going with the thought that we do need to control stress and optimize loading on these healing tissues, we do need to know from the beginning, well, how much are those tissues able to tolerate? So we are looking at single limb balance testing, hopping within a safe range or with upper extremity support to see. And as we have the individual and we're looking at that kind of quality versus quantity of these movements, when we have the individual on the right here who's performing this single limb stance, well, are they unstable because of their ankle? And questioning them, well, is it pain in your ankle that you feel is causing you to shift your weight? And can we correct that? Or is this a weakness of the hip abductors? Is this a weakness at the knee of the hamstrings and the quads? What is actually contributing and honing in? Is it the ankle or is it elsewhere up the chain that we also need to be mindful of? Our specific provocative tests to assess the different ligaments of that ankle complex. The medial talar tilt test. This is going to look at the medial force that will be applied with the ankle in neutral to that talus and the calcaneus. A classic test that we know is our anterior drawer test, where we have the individual in that unweighted position, and then we are going to be be stabilizing the tib fib, and then we're going to do that anterior translation to see if there is that laxity with that foot in neutral. What they're finding is that with the foot in the neutral position, the deltoid ligament can provide some stability, so it's not always accurate, which has led to the utilization of the anterior lateral drawer test. This is where the foot is going to be placed in only about 10 to 15 degrees of plantar flexion. And then it's the same position where we're doing that anterior translation and we are palpating that anterior talofibular ligament to see if there is translation. We know, having done this, that that takes a lot of mental concentration to distinguish our force of pull, our force of stabilization, palpate for any translation. And what they're finding is that in many percent of the cases that ligament laxity is not detected. It's estimated that in about 28% the anterior talofibular ligament laxity is not assessed. And then in those patients that have involvement of the calcaneofibular ligament, also almost 40% is missed. Not because we're performing the test wrong, it's just because proprioceptively and cognitively, we can only do so many things. So while that is a better version than the anterior drawer test, what can be utilized additionally to provide more specific information is the reverse anterior lateral drawer test. This is where you place your patient in a hook lying position. You can put a little roll under the foot if you need to, like a towel roll, to get them into that little bit of plantar flexion. Now, what you can do is your hands are free to be more precise in what we're asking of them in terms of demands of our own proprioceptive system. So, what we're going to do is, in this case, we are going to try and translate that tibia posteriorly on this fixed foot. And that is then going to allow us to better assess the laxity because now we can palpate those ligaments and see if there is translation. While that deltoid complex may provide a little bit of stability, more so with the anterior lateral drawer test because you can kind of pivot around it. In this case, with the reverse anterior lateral drawer test, we can more accurately assess the excursion to see if there is involvement of that ligamentous complex. Medial ankle sprain, coming on to the other side of our ankle now. The mechanism of injury is going to be a pronation, abduction, and dorsiflexion type of injury. This is often likely to happen when the individual's body weight is going to fall. We might see it in someone who soccer, hockey, dancing, skiing. What they are finding, looking at military personnel, that the majority of, I think it was about 60% of the military personnel, when they looked at this one cohort that presented with medial ankle sprains, that 65% were sport related as opposed to training and task related. So I think that's a good example because when you think of the rigors that our military personnel go through in their training, the fact that more were sports related gives us a little bit of insight. And then also, as we're rehabbing our patients, to be mindful of this, that we want to make sure that if they are going back to recreational activities, that we do train them to be prepared for that. It is going to be involvement in that medial complex, so we will see ecchymosis depending on the severity of that injury. What we want to be aware of, particularly for the medial ankle sprain, is again coming further up the chain into that distal lower extremity. You're going to want to come and palpate all the way up the fibula in this case. Now, you might be thinking, well, medial complex, those are originating around the tibia at the ankle, which is true. What happens is because of that force, think the foot is usually planted in some way, and then the force is coming up as the body weight goes down, ground reaction force coming up. It actually transmits through that medial complex of the ankle where you might have a little avulsion fracture. It's going to come up diagonal through that fibula in this way, and then the individual might have a proximal fibular fracture, which is called a Moissanville fracture. My New York accent does not want to say that, but that is the fracture that can happen of that proximal fibula. So please make sure you're assessing all the way up. And if you have that patient that has had an ankle injury, maybe it's a low grade sprain, but they're not healing, they're unstable, they're complaining of pain, we need to ask our patients where specifically is that pain and not assume that they mean the ankle, because it could be that proximal fracture that now, over a little bit of time, and now that they're rehabbing and weight bearing more, has just shifted enough that it's becoming more evident for them. Our last type of ankle sprain that we'll take a look at is the syndesmosis ankle sprain. This is going to occur of that complex that is working to hold this tibia and fibula together. As we have different forces coming up, ground reaction forces, body weight coming down, and torsional forces, this tibia and fibula want to be splayed apart, and we have the membrane and the ligaments that are holding everything together. So a syndesmosis sprain can also be referred to as a high ankle sprain. And the individual we're going to look at in the image on the right is not the boy in the front. We're actually looking at the boy in the back here, where his foot is planted. It's in somewhat of a dorsiflexed position because think he's translating over his weight onto that foot. And now, if someone came and I want to say tackle, but I know that's not basketball terminology. Someone impacted him in this way, and his body weight went forward, and his foot was planted. That's causing internal rotation of that tibia, and then that foot is actually externally rotating, and the body weight impact is going to separate that tibia and fibula from each other. So that's going to be our syndesmosis sprain. When we look at the implications of this, it can be very destabilizing of the foot because any force that then tries to come up to go through that extremity to take any step, if that tibia and fibula are separating apart, the individual is going to be unable to take that step. And this is how you can help distinguish that person from someone who had a lateral sprain. Also, you're going to see the swelling and pain is going to be a little bit more proximal, closer to the tibia versus down more on the dorsum of the foot because of the ligaments involved. The individual is not going to want to perform any activities where that tibia and fibula are splayed apart. So even during our rehab, we're going to make sure we're putting further off in our rehab any activities where we're having that moving into that mid stance to push off, where we have that wide part of the talus going between the tibia and the fibula to splay them apart. There's a variety of provocative tests that can be utilized in order to try and hone in on this specific diagnosis. The squeeze test is the more common one, where you're going to squeeze the tibia and fibula together, and you might get a little click and shifting of those bones that would lead you to this diagnosis. But the research really says it has to be a combination of assessments in order to identify this specific diagnosis. And again, this patient is going to have difficulty stepping. They're not going to be able to bear any weight. And we're going to hold off until later in rehab with any type of impact activities or forces that are going to try and splay that tibia and fibula apart until those ligaments have really healed. So watch on different incline surfaces, watch on how far you have them reaching with the different balance activities. As we go through our assessment of individuals following ankle sprain, and we are taking a close look at the various soft tissues and the movement of the joint surfaces, we are also going to consider the neurologic potential involvement. Ankle sprain neuropathy can occur because of either the external load and forces that are applied that may directly traumatize different nerves that might be more superficial in that distal lower extremity foot and ankle region, or because of the internal pressure and the swelling that could be occurring that can create trauma to those nerves. Specifically looking at the peroneal, our peroneal nerve is often involved when there is an ankle sprain, particularly a lateral ankle sprain, because it is tethered at both ends as it goes through that lower compartment of the extremity into the ankle. And because it's tethered in the fascia, when you have that ankle sprain that overstresses the tissues and it pulls on the soft tissue, then it can pull on that nerve, creating trauma to it. So it's important that in all of our patients with any of these ankle pathologies, different types of sprains, that we do perform a neurologic assessment of all the different nerves to make sure that there is an involvement of those nerves that additionally needs to be addressed. Now, it's more likely to be transient, but again, we do want to be aware of this. When we're doing our assessment of patients, we're looking at, do they have any tingling, burning, specific decrease in sensation that has occurred. And then again, we want to be aware that for the most part, these are going to be purely sensory in nature. If we're also seeing motor weakness that relates to a specific nerve, or even myotome, if we're seeing reflex changes, then we might be thinking something else. If that's our patient who also has spinal stenosis or herniated disc, and now they have an ankle sprain because they've been compensating or had an episode of loss of balance, we kind of need to tease out which signs and symptoms are coming from which pathology so that we can appropriately address it. Also, something to think about longer term managing these patients, chronic regional pain syndrome. We do need to monitor patients for this. They're finding that, particularly in pediatric patients, those that go on to develop CRPS in that distal lower extremity, that there is a history of some type of trauma to that foot or the ankle. So we want to be mindful of this. Ankle sprain management is going to be specific to the complex involved. Since the lateral ankle sprain is more common, that's a more of where I am going to focus in our discussion. I'm not going over everything to repeat information that you already know. I'm going to highlight more of the trends that we're seeing in the current research that hopefully will affirm what you're already doing. If this sprain is severe, then we might be looking at more surgical intervention. Mobilization, specifically Mulligan mobilization with movement, is what is most recommended, because this is where we're working in the range where the patient actually has the restriction. So for looking at that talohural joint, so that talus being able to glide with the tibia, We're going to have our patient in a weight bearing posture. They could be in a kneeling lunge, like in the image, a standing, just standing stride, performing a standing lunge. If they can't do that, the patient could just be sitting with that knee flexed and weight bearing down through that foot. The clinician is going to apply that force to hold that talus in place and be pushing posteriorly on that talus while the patient is leaning their weight forward to glide that tibia, and we're working on restoring that glide, stretching out those periarticular structures, that joint capsule, those ligaments for that controlled healing to encourage that movement. So the clinician force is going to be going onto that talus, and then the patient's weight bearing force is going to be moving forward into that lunge position for that mulligan with movement to work on that specific positional fault. And then you can work in the ranges where your specific patient is having difficulty with their stairs or their sit to stand or in the specific component of their gait cycle. In terms of other interventions with manual therapy, we're performing this within a pain free range of motion. We'll be looking at lymph drainage, soft tissue mobilization coming all the way up into that entire calf region. Ultrasound is not recommended, as we're seeing as a trend here. Acupuncture and electrotherapy have conflicting recommendations as we go through our research. However, cryotherapy may be indicated intermittently. We did just have the whole discussion about how ice is not recommended because it inhibits the body's healing. That's why it's only a really weak class C recommendation for that cryotherapy. Probably not something that you're utilizing, but I did just want to mention that here. As we look at the different types of functional support that can be utilized, there needs to be a balance based on the degree of the ankle sprain in order to preserve motion so that the tissues do not tighten down too much, but also limit those extreme positions that are going to disrupt those fibers that are trying to heal. So, if someone has a more severe sprain, they may be in a boot for a period of time if it's not managed surgically to allow a little bit of healing to occur. And then they're going to move some more type of flexible bracing system that allows more of that controlled motion. The idea is that that gentle tension on those ligaments that are trying to heal is going to allow those fibers to align in more parallel orientation. The other key here for ankle is proprioception. We need those afferent fibers to be stimulated. If someone is immobilized, that is not happening. And that loss of proprioception leads to poor timing and recruitment of the stabilizing muscles, particularly peroneals, that leads to the risk of re injury. And if we look, it's maybe someone who already had compromise in that area. So that controlled motion is stimulating those afferent fibers to help maintain that proprioception in small ranges, pain free as the tissues are healing. And that's just how I picture it. We, as clinicians, we're so bound to that relationship. You need to stretch a muscle, gain the range, and then teach the antagonist muscle to work in that range as well as the agonist. I think we can also, related to ankle sprain and a lot with the ankle, take a look at marrying proprioception with that. That as we are learning to get more excursion of those ligamentous structures, of the all of those soft tissues around a joint, proprioception needs to come along hand in hand with that. So earlier on, you might be starting, just with the foot resting on the floor, weight shifting or leaning forward. Hardly any range is happening, but we're getting some proprioceptive feedback or bracing that allows those small ranges of movement for that proprioceptive feedback to happen. When we look at the clinical practice guideline, for example, from the American Physical Therapy Association, that 73% of individuals are at risk for respraining. So we need to restore that proprioception in order to decrease that risk. That there might be some benefit to prophylactic bracing, for example, in specific sports, having been a volleyball mom for many, many years, and I'm sure all of you experience this at some point. You're like, nope, I'm just a parent here. I'm not a therapist, right? Treating one's child. But you see those ankle braces going on with the strap to prevent the inversion on the wrong side of the foot as the child's putting their brace on. Oh, we've all been there, right? It's a reminder that with all of our patients, regardless of age, that the education needs to be there as to what the brace in the sport is supposed to be doing. Can it appropriately be applied independently by the individual, or do they need assistance to make sure that it's doing what it should do for control? Looking at some specific outcome research on different types of functional support, bracing isn't the only way. As I mentioned, there really is no consensus in the research as to the best type of bracing that should be utilized. Um, for individuals. When we look at using tape specifically, there was a study that looked at individuals with grade 1 and grade 2 ankle sprains within the first week to 3 weeks, where they were utilizing ankle taping in order to provide some external stabilization but still allow a little bit of movement for those proprioceptors to kick in and give feedback for recruitment, eyes open, eyes closed, balance. They did find that individuals were able to more symmetrically load, which would lead us to believe that proprioceptively they're getting some input, which would carry through to better rehab outcomes. In terms of kinesio tape, I'll be honest, the research is not quite there for ankle sprain. Looking at single limb dynamic balance when the kinesio tape was immediately applied, yes, there was that immediate improvement. However, when they looked in that static balance, but when they looked at dynamic control in terms of recruitment and muscle stabilization, there really wasn't any difference between that and the sham. Now, granted, it was a small cohort study, this particular one that I'm referencing, but as I looked at other research, trying come up with a little more solid answer for everyone. Larger reviews, their specific wording is they cannot support or encourage the use for functional performance of kinesio tape of that foot and ankle for the ankle sprain patient. Functional therapy is something there is more consensus on. That this means having the individual actually moving in functional movements and having them recruit their musculature. We're looking at stretching, we're looking at basic, open chain strengthening of the ankle, maintaining strength more proximally, and then that focus on proprioceptive training and reaction time. In order to accomplish this, there's a lot of ways we can do this. It's not just basic ankles exercises with TheraBand. We can have our patients standing, doing different weight shifting type of exercises. If they're a lower level patient, maybe it's that older patient who had a total hip replacement or a stroke and they've sprained their ankle, and we're incorporating that into the rehab. Maybe they're sitting doing different weight shifting exercises, just having that foot resting. Whereas our higher level patients, if they're in this plank position, they're maintaining their upper body, working their core, but this will also be working on ankle stabilization for that individual. So you can think of dynamic balance control and activities in a lot of different ways. Several different studies that compared individuals who were just doing over a 6 weeks period, twice a day, 20 minutes of TheraBand straight plane ankle exercises versus those who went through that rehab program where they were using the Dynadisc, the Bosu ball, single limb stance, doing more reaching and lunging in controlled, pain free ranges to be functional. They did find improved outcomes for those individuals and were performing more of the dynamic exercises. Also, they found that those individuals had lower pain levels associated with that. As we look at gait analysis, we know that when our patients are rehabbing from this injury that is going to not allow or that cause disruption in the stabilization of that ankle, we would expect specific gait deviations to occur. So where we might see in these individuals where they're going to have more of a rear foot inversion, where their calcaneus becomes inverted. The hope is that through strengthening and healing, that is more aligned, but we do want to take a look at that, because as there is that inversion, we need to see, well, is it more just positional? Do they need more plantar surface massage and plantar flat fascia releases and work here, midfoot mobilizations that I mentioned earlier? That why is that foot not aligned? We don't want to just assume that it's because of the ligaments that were involved in the initial injury. So we want to take a look at that, because during mid stance, it's important that all those structures work together so that this foot becomes that rigid lever for propulsion through that gait cycle. That will decrease the risk of re injury for that patient. Also, allow for better shock absorption and less trauma to other joints and risk of arthritis. We're looking at the tendency is that there is greater plantar flexion, which means tightness we know has developed in that gastrosoleus complex. So, if there is tightness in that gastrosoleus complex as the individual is trying to go into that heel strike position, well, that might limit this knee extension at that terminal swing just before initial contact for the individual. Now our step length is less, our velocity is less, and we have this cascade of events. So the research is saying not only do you need to look at the knee and ankle in terms of that extrusion of the gastrosoleus complex, but also that hamstring, that if the individual hasn't been walking with their typical gait pattern, that hamstring could be tight, and we all know to stretch it already. What we really need to train for that end of the swing phase is the eccentric control of that hamstring to help position that limb. So we need to make sure we're doing eccentric strengthening of that hamstring for our patient and coordinating that with our balance exercises and our heel strike, looking at timing of the peroneals for balance. And thank goodness we have technology now that can allow us to do videos and look at more of this precisely so we can hone in on different pieces for our rehab program. In terms of jumping, if we have individuals going back to different sports or different work, and we think, well, who really jumps other than an athlete? As you watch any of these delivery workers, they are hopping and jumping all over the place. Think of individuals maybe who work on farms and they're moving out of the way of different animals or equipment, or stepping over different things. So jumping may come in different ways. What we're talking here is more of a high jump. So when someone jumps up and when they come down for their landing, usually they're going to land on the forefoot and then decelerate down for their landing. The peroneals need to kick in to have the foot in the appropriate position. But again, once the foot's in the appropriate position, now it becomes that eccentric gastroc. So we need to make sure that for load transmission, to avoid, risk of ankle arthritis, that we train those gastrocs eccentrically for that individual. So looking at progressively, higher distances of the jump and landing, just as we would with our patients with step ups, that we progressively increase the height. Chronic ankle instability, this is looking at the same individual but at a different point in time. So our hope is that we have rehabbed our patient who had the lateral ankle sprain through everything that we just discussed. I look at the gait deviations and the research studies that detail those, that say, well, this is what we're seeing in patients who have had ankle sprains. Almost, I see that as my to-do list or my goal list for before I discharge them from rehab. So, as we look at chronic ankle instability, this is that individual who has had a history of an ankle sprain. And now that individual is continuing with deficits. So typically, the continuum is someone has an acute lateral ankle sprain in those first 1 to 2 weeks. They are going to have that acute injury, and then they're going to go through rehab, and they are going to be what we call copers. They've coped, they've healed, they've gone through rehab. So within 12 months, they've recovered all their function and they're good to go. We do have a cohort of individuals who actually go on past that 12-month period and they continue to have challenges with their function and with their pain and movement in their ankle. This is actually a global health problem to the point where there has been the development of an international ankle consortium that came up with a specific definition for chronic ankle instability. So it's an individual who had one ankle sprain, but they have these feelings that their ankle is giving way, like they can't trust it, or I think I'm going to resprain it, or it actually has resprained, where it just doesn't feel right. And then function has been identified as being compromised based on different tools that we utilize. So, this chronic ankle instability, when we have that individual greater than 12 months out from an ankle sprain and they still have impaired function, they still have pain in that ankle, they're reporting that they're functionally unable to perform certain activities. We're not saying that it's in their head, we're not saying it's not a real condition. What's been identified is that these individuals have low self reports of function, that often these are the individuals who 6 months into the rehab from their original ankle sprain, they're progressing a lot slower. They are not moving as much, even though physiologically their tissues might be able to, they might be ready. And what they're finding is it's not a lack of rehab, it's not a lack of desire, it's actually they may not have had sufficient neuromuscular training, so that proprioception piece coming in, that they may be getting the feedback that they can't trust that ankle because of that lack of proprioception. So an important component then of assessment of these individuals is for with chronic ankle instability is a self-efficacy questionnaire to see, well, what is the confidence that they have in their ankle, kind of what subconsciously might be kicking in that's not allowing them to move. So it's going to ask them specific questions about that. The kinesiophobia, that fear of movement, Tampa scale, the threshold score, we're seeing of 37 as those individuals who have a fear with activities of fear of movement. They're worried about re-injury. They feel like that ankle is giving way, which it may or may not be. It might just be that altered proprioceptive feedback. But this tool looks at the actual performance of activities based on the patient perception to help hone in on that and see if you really need to focus on proprioceptive training, or are there additionally different soft tissue aspects. And the fear avoidance questionnaire is another one that's utilized for other regions of the body that has been identified as beneficial for individuals with this chronic ankle instability, looking at their beliefs related to work, recreation, functional tasks, and it has been determined to be suitable for individuals with chronic ankle instability. So, where does this put us? Chronic ankle instability has two branches coming out. There are those individuals who their tissues have not fully healed appropriately, and those are our individuals who have a mechanical ankle instability. There, the terminology with all of this is somewhat debatable in the research. I will be transparent with that. What I'm presenting here is what most of the research seems to align with. So, in terms of classification, there are those individuals who may still have some pathologic laxity of that lateral complex. In that talocrural joint or subtalar joint, maybe there are some osteophytes that formed, or they have significant capsular tightness that is present. There might be restrictions or scar tissue. Maybe degeneration has set in depending on how long it's been with abnormal forces. There's some arthritic changes or synovial changes that have occurred. Those are individuals where there might be very specific conservative management or surgery might be needed. Where we're going to take a look now are those other group of individuals that truly have functional ankle instability, where anatomically the structures are intact. When we do our assessments, our provocative tests, maybe even on imaging, everything is showing that the tissues have healed. However, these individuals have an impairment and a decrease in their proprioception. Maybe it's also in the strength of the muscles. Postural control is going to be altered. They're also finding further up the chain that the individuals tend to have more of an involvement of hip abduction, extension, and external rotation, because everything is connected within the gait cycle. And those proximal weaknesses that don't allow appropriate foot placement, combine that with the decreased proprioceptive feedback, or not fully accurate proprioceptive feedback to allow timing of the peroneals and ankle muscles. Then we have an altered hip and knee placement. That person's like, oh, this ankle's going to give out. I'm not going to do that. It is where we are at, leading to that kinesiophobia. So there are several contributors that they have found that put individuals at this increased risk of being that person that hasn't regained full function, that after that 12 months out and has that fear and instability feeling that they can't trust that ankle, or have actually resprained. And again, I look at this list as for my intake of someone coming to me at the chronic ankle instability diagnosis portion of what I need to assess and work on. And then I also have this in my mind when I'm looking at discharge and goals of someone from that initial ankle sprain, to hopefully have them fully heal and not end up being this patient coming back, to the best of our ability, of course. So, contributors that they're finding, as I mentioned, is that lack of proprioception and kinesthesia, inversion, and eversion. It's weakness, and it's weakness to the point where those peroneals are not reacting when they should. How do we see that evidence? When you're assessing balance, you're assessing single limb stance in this individual, or just looking at a gait analysis, look at timing and reaction time. This is the individual where they might have heel lifts or foot lifts during balance, where they might not stabilize immediately with an ankle strategy. They're using more of a hip strategy for their balance with a smaller perturbation, or maybe even they won't even go into that position where those peroneals should be kicking in terms of range of motion. Gastroc soleus tightness with the standing weight bearing lunge test. There was a study that looked at firefighters who have high demand activities, and they found that greater than a 2.5 centimeter difference in excursion of the gastrocsoleus complex from the involved to the uninvolved side altered the kinematics enough that it put individuals at a greater risk of developing chronic ankle instability. In terms of postural control, that glute medius activation is important by controlling that positioning of when we look at our hip, if someone's going into a squat where they are, we know, doing that for many different types of activities. If you have that hip adduction occurring, it alters the mechanics at the knee. We go into more of a valgus, and now those peroneals are placed on a greater challenge. Um, so that again, if it's a weak peroneal or it's not giving appropriate proprioceptive input, leads to greater challenges and feelings of instability for this individual, decreased shock absorption. So this patient, we're really going to want to look all the way up the chain, hamstrings, quads, all those different muscles also, to make sure we have appropriate kinematic alignment to get appropriate feedback for all the balance training and proprioceptive training that we are doing. Looking at different rehab outcomes, some specific examples for populations of individuals who presented with chronic ankle instability. They looked at female athletes who had the functional ankle instability. They had them using a wobble board. They did find improvements in their overall outcomes. To target a little bit more of that kinesiophobia component, to kind of take the cognitive piece out of it a little more and let the proprioception just kick in. We have so many more options now with different virtual reality type of activities. So they had football players doing these different virtual reality games where you would obviously be directing the game in a way so that the individual is moved into those positions to stress that ankle and work on those peroneals. They did actually find that there was greater self-efficacy, feelings that they could try different activities. And wow, I was able to accomplish that and trust that ankle, less fear avoidance that occurred. And we could see that translate into so many different populations, not just our adult population, but our elderly population as well as pediatric. Looking at some specific performance instruments and what directions of movement for work or function gave the most feedback related to individuals with chronic ankle instability. Looking at large systematic reviews, there was moderate to strong evidence coming out of this study from the University of Nebraska that specifically the side hop test, because this is going to be a greater frontal plane challenge and challenge those peroneal muscles more. It disrupts that stability, that it seems to activate the peroneals greater to help rehab individuals who need that strengthening. So you can use this in two ways. It means you would probably hold off on your side hop until later in rehab after the initial injury, and it will then be a greater focus for your patients with chronic ankle instability. Also, as we said, looking at foot lift better. So you might be setting goals for patients, really for your chronic ankle instability and other patients that we'll talk about today, where you're going to have them balancing, count how many times their foot lifts, and decreasing that can be an indicator that they're developing better strength and proprioception. And that could be with any of your different balance activities, and compare it possibly to the opposite side. Sensory targeted ankle rehabilitation. This is the theory that those damaged sensory receptors in the ligament lead to deficient processing and deficient input afferently that compromise motor output to the targeted muscles that then compromise their recruitment, balance, risk of re-injury, and that cascade. And I'm sure you're already performing these interventions, and if we look at them based on this research and the consideration that our goal is really proprioception in addition to range or strength, it might help the patient buy in more also if we're having them do this at home. For example, plantar massage. So, twice a day, 2 minutes of plantar massage was utilized. They found that that component of this program specifically led to improved single limb balance 1 month out. Ankle joint mobilization, like we've already discussed, this is going to lead to those improvements in range. So they were doing AP gliding. This happened to me open chain in this particular study, grade 3 mobilization, non-weight bearing, 2 for 2 minutes to increase that excursion. They did find significant improvements in that weight bearing lunge test. And then in our basic tricepsori stretching for the individuals, 2 sets of stretches held for 30 seconds in standing. Combining all of these interventions together with the other components of rehab, they felt that these targeted interventions help to tune in that sensory motor system in order to have better rehab outcomes for these patients. Taking a step away now from those ligamentous injuries, we'll just want to mention traumatic ankle and foot fractures. The Weber classification is what is utilized, looking at these fractures in pediatrics and adult patients involving that lateral complex. Our type A is going to be occurring distal to the ankle joint where that fracture would be located. Type B is going to be higher up, more at that level of the ankle joint. And then type C is going to be up a little higher, more on that proximal fibula. You want to consider this if you're seeing patients more on the sideline or if you're seeing them for other conditions through direct access. If you need to assess to see if there possibly might be a fracture that has occurred, or if you're the one getting those results, this gives you a little more information about where those fractures are going to be located. The tool that really is going to lead us down the path as to whether or not imaging is necessary are our Ottawa ankle rules, and this should be utilized for all patients that have sustained any injury to that foot and ankle complex. They estimate that by performing the Ottawa ankle rules, it decreases unnecessary imaging studies by about 30%, which is significant. So if we're assessing someone and they have malleolar zone pain, so if there is tenderness on that posterior tip of the, wrong side, posterior tip of the medial malleolus, or the edge of that tibia going up approximately 6 centimeters, or if the individual has the same thing, the tenderness up that fibula or just at the tip, they're unable to weight bear or walk 4 steps, so they can't put any force through that limb. That might let us know that that individual potentially has a fracture and needs that ankle x-ray. Someone who has tenderness of the navicular here in the green, or at this base of the 5th metatarsal, and again is unable to weight bear, that's the patient that might need that foot x-ray. To be aware that in children under 5, the Ottawa ankle rules are really not reliable, because it relies on the individual's report of tenderness or discomfort, and children are really unable to do that accurately below that age. Also consider your patients who have decreased sensation or impaired sensation of pain because of spinal cord injury, diabetes, other conditions, that this might not be accurate. Pylon fracture, I do want to discuss so that we are aware of it. If you haven't heard of this condition, a pylon fracture will occur in an individual when there is a significant high axial load force. So, where there's a significant force that has, either ground reaction coming up or vertical force coming down, where this talus has been jammed up in between the tibia and the fibula. Now, we did talk about that related to a high ankle sprain, where there is that kind of twisting force that has occurred with the diastasis. This is much more traumatic. It's usually seen in individuals with multi trauma. Oftentimes, actually addressing this fracture is put off until the other life sustaining measures have been performed and the individual has somewhat stabilized. But the risk of significant long term loss of function of the ankle is high. So I like to mention it. So if you are seeing multi trauma patients, just to continue to be mindful of this diagnosis. It's where the individual sustains a significant fracture of the fibula, the tibia. There's significant damage to the surface of the talus for that individual. Usually, they are going to require surgery in order to manage this. The key point, if you are seeing the patient and they're just monitoring this fracture while they're doing other life sustaining measures and treatments for that patient, could be over days, maybe even longer. You do want to keep assessing that foot and ankle because the amount of neurovascular compromise is extensive. So we're checking if we can for a pedal pulse. We're looking at circulation going down into that toes. We're monitoring that swelling. There's a lot of positional tension that's placed on the neurovascular structures. So that's what we want to be aware of immediately. And then longer term in rehab, being mindful of this if the patient does have this fracture and you're seeing them post operatively, keep in mind that you definitely want to be assessing sensation and circulation as components of your rehab. Our calcaneus fracture is something that has many different names. This has been referred to as the lover's fracture, Don Juan, Casanova, the list goes on. Not to make light of this traumatic injury because it is. It often happened when suitors were falling off the balcony or jumping off the balcony to try and escape, usually the parents of their beloved, and they sustain this injury by landing on that calcaneus, creating a fracture, and then the force is usually transmitted up further. We're going to want to assess these patients also for lumbar compression fractures. Where I have more often encountered this specific fracture, we see it kind of going through here, are individuals, roofers falling off and trying to land on their feet, and they sustain that loading force coming down. The assessment that we are going to perform for this is going to be the calcaneal squeeze test. So if we squeeze the calcaneus, we could be shifting those bony segments, so that will replicate pain for the individual. Squeeze test, you've heard multiple times already in this presentation. So when you are documenting this in your evaluation and assessments, we want to make sure we're specific as to what structures it was performed on, because if it is more of the ankle squeeze test, that's looking for a high ankle sprain tib fib movement. Calcaneal squeeze test is looking more for a calcaneal fracture. And that'll really be important to distinguish as we look at soft tissue pathology, where you're ruling out other injuries. Um, Conservative management is going to be based on the severity of the fracture. The individual might just be adult or pediatric patients. They may be non-weight bearing in a boot for a period of 3 weeks, and then they're going to be moved to some degree of controlled weight bearing for 5 to 8 weeks, with a progression, hopefully by 9 weeks, to be full weight bearing. What you might notice on the individual, because of the significant amount of edema that occurs In the foot, looking at the image on the right, we see this blistering that's occurring. This is not from a calcaneal fracture. It was just the best image that I could show. In the foot, there's not a lot of adipose tissues. There's not a lot of fat under the skin. So when there is a significant amount of edema, it may actually leach out and create that blister that we're seeing. So this would be a fracture blister, and you would see it more on the posterior or hind foot region if it was the calcaneal fracture. They're finding that in pediatric patients who have a history of calcaneal fracture, that they are more likely to develop chronic regional pain syndrome, particularly in girls just prior to puberty. They're not sure of the relationship, but they're finding somewhere between 73 and 87% of children that go on to develop chronic regional pain syndrome that they have had some history of fracture or significant trauma to the foot and ankle, and then they're already showing patchy osteopenia down the road by the time it's evidenced. So we do want to be mindful of monitoring those skin changes, those sensory changes, the sweating, the hair growth, etc., as well as monitoring for compartment syndrome. When we look at rehab after the individual has healed the fracture, we'll look at doing our toe curls. We'll look at our towel work to we definitely incorporate the toes. We want to remember, splaying of the toes out, lifting them up individual to regain that intrinsic strength of the foot, doing our doming type of exercises to restore control of those intrinsics for the arch of the foot. Mobilizations might be needed all the way down. We need to make sure that we restore in all of our foot and ankle patients. This is just a good time to bring it up. You need, in order for that push off phase of gait, we need to get 65 degrees of great toe extension. So we want to make sure that we achieve that for the individual also. Looking at the Lisfranc complex injury, this is a fracture dislocation type of injury that occurs. It's purely ligamentous, and is the Lisfranc. The medial cuneiform should articulate with our second metatarsal, but we see here there is a significant space and altered alignment here. This is an individual who, when they fall, their body weight coming down is going to separate out as their body weight comes down, or they fall backwards. Let's say you have someone in rodeo or equestrian activities where their foot gets stuck, or under industrial equipment. It's going to splay this joint out, and that is a keystone for maintaining the arches of the foot. So it causes significant disruption in the alignment of the foot. Also consider your patients who, when they are in a motor vehicle accident, look all the way down to the foot, because if they're in the motor vehicle accident, when they're pushing on that brake, and then depending on the force of the accident that's coming, it can create that force that will separate this joint out. It's a ligamentous injury, but there can also be a concurrent fracture that occurs with it. This is an example of an individual who had a farming accident, and they, for several weeks, they were still walking on that foot, slowly losing their mobility. If we look, we see complete distortion of the foot, loss of the arch, because that keystone that balances those longitudinal and transverse arches now has been disrupted. This is the patient, anytime they try to go into that push off phase of gait, they are going to have significant pain because there is no rigid lever to push off from. If we do a tarsal metatarsal squeeze test, we're going to be squeezing across that disrupted joint and ligament. So that's going to create pain for that individual. So there's significant disruption that has occurred there, loss of function for that individual that we're going to see in the foot. Compartment syndrome is something else we want to monitor for because there will be a lot of swelling that has occurred. Conservative management might be appropriate where the individual is left non weight bearing for up to 6 weeks to try to get that ligament to heal during that time. Like our other patients were maintaining hip strength and core strength. It might be 3 to 6 months before you're able to normalize gait for this individual because you need to slowly and the weight bearing back in. Because this is key to creating that rigid lever for propulsion of gait, you don't want to do that too soon and disrupt that ligament that is trying to stabilize everything. So the individual might need some type of orthotic or something a little more rigid in that foot and then slowly work them towards that mobility. So be mindful of this when you're looking at starting your weight bearing. You might just start in sitting, look at going smaller ranges, not as far of directions and excursion. Stress fractures can also occur in our patients, looking at the bones of the foot. Some of the thoughts related to stress fractures is that as there's persistent loading on the foot, so whether the individual is doing repetitive running or they have a job where maybe they're using a jackhammer or they drive a piece of equipment where their foot is, on the brake or just on the surface that's vibrating and moving a lot, creating force coming up, that persistent loading creates a little bit of microtrauma to the smaller tarsals of the foot, metatarsals, sorry. Um, they're unable to heal because the force continues, and then it leads to overload and eventual fracture of those bones as the bone fatigues. Commonly, we're going to see a fifth metatarsal fracture in rehab. This often, as I said, occurs in someone maybe who has been running or other different types of work related activities. They're going to have lateral forefoot pain that's exacerbated when they do weight bearing. When you have that patient toe walk during your evaluation, that's going to really increase the pain for the individual. If we look at their foot alignment, the individual may have more of a varus hindfoot, so that calcaneus coming in, and we see when that happens, there would be excessive weight bearing on that fifth metatarsal. So every time they're running or working, whatever it is, that force is going through there, putting greater stress on that bone. There's going to be weakness of eversion because we also have our peroneal that attaches right in that location. So we'll have pain with resisted eversion and then passive on our inversion. Also, be aware that our patients with certain comorbidities are at greater risk of not having good integrity of the bones, particularly the smaller bones of the foot, who have metabolic bone disease, someone who has different endocrine type of pathologies, diabetes, hyperparathyroidism, nutrient deficiencies might be at greater risk of these stress fractures. So in your differential diagnosis, you'll be putting those pieces together. The other cohort to consider when we look at the risk of these stress fractures are our female athletes who present with the female athlete triad, where they have low estrogen levels that are evidenced by less frequent or non occurring menses. They don't have sufficient vitamin D and calcium intake for that bone building that places them at a greater risk of osteoporosis. Then, if they're also involved in activities, our military personnel, athletes who do extreme levels of activity, and even workers or laborers where their um, food intake does not match with the metabolic demands and they have these other components, they're at a greater risk of developing these stress fractures. So if they're complaining of foot pain and discomfort, we do want to have a stress fracture as a possible consideration. As we continue to talk about metatarsal fractures, specifically looking at the fifth metatarsal, there are different regions to this fifth metatarsal bone. Depending on where the fracture is, it's going to change the rehab that is necessary. So, a zone one of avulsion fracture is going to be of that little tip of the bone, that is going to be someone who has sustained more of an acute injury. Same thing with someone who sustains a zone 2 injury, where it's more the metaphysis. These are more of our avulsion type, or acute type of small fractures. The individual is going to be non weight bearing for 6 to 8 weeks in order for some healing to occur. The concern in this zone 2 area in particular is that we have the nutrient artery that is coming from distal, and then we have the metaphyseal artery coming from proximal, and there's that little watershed zone in between. So, with that zone 2 and zone 3 fracture, we have to be concerned with avascular necrosis. That's why we're going to really be cautious in our weight bearing and limiting that early on. And then as we slowly progress the patient, if they're doing well and then suddenly have an increase in their pain, decrease in their ability to weight bear, that might be a concern that we have a non-healing fracture in that area for the individual. So what's considered the stress fracture is in that region of where we're looking at zone 3. So that is more proximal here on the imaging that we're looking at. Again, this will be managed more conservatively in some type of boot or shoe, where the individual is non-weight bearing for longer, probably up to more like 12 weeks, being cautious with their activities. We're going to watch as we move the patient back into rehab them and get back to weight bearing. With most of these patients that we're discussing today, just resting the foot and in sitting being able to weight shift, just putting the foot on floor gives some force through that foot, and then moving, then work up into standing, then think if they have a job or even if they drive at all, they need to be able to push on a pedal and weight bear through that. They need to be able to hold a weight. We all carry different things, and depending on the job, it's a greater load. So, for all of our patients, as we look at balance training, strengthening, balance, we're looking at changing the angles of the surfaces they're on, the whether they're stable or unstable. Particularly with this, we're also thinking about the amount of weight that they are carrying or having come through their bodies, and then being able to move that in different directions. Then looking at progressing those patients to more of their jumping and hopping type of activities as we know more healing has occurred. Osteochondral lesions of the talus. Now we're looking at this top surface of the talus here. So we're moving away from the cohort we were just discussing with the stress fractures. Now we're back to thinking more of our patient who has had a significant trauma to this foot and ankle complex. They may have also had an ankle sprain or a calcaneal fracture or a high ankle sprain, or maybe it appears that they didn't have any injury. And down the road, they're starting to develop kind of this deep seated pain in their ankle, this clicking and this popping movement. What happens is this cartilage on the surface of the talus can become damaged when there is that high force trauma that goes through that ankle. What happens, as we're seeing in the image on the right here, is that it can happen one of two ways. The individual can get these little fractures in that talar dome that we're seeing on the arthroscopic imaging here. And then the synovial fluid leaches down into the bone matrix. And now we're going to have osteonecrosis that occurs. Another way that this can happen is osteochondritis dissecans. So we see this more on the image on the right, the imaging studies, where there is an area where there was significant impact to the bone and a little section of that cartilage loosens and removes itself. Well, now the patient doesn't have a good, clean articular surface either. This might happen, several weeks or months where they're really feeling the pain from this after the initial injury. When the person is going to feel this, I think of this like that meniscus involvement at the knee, that as they're flicking over that tear in the meniscus is when it will cause trauma or pain, replicate the symptoms. So the individual, when they are going into let's say they're going to do jump. So they squat down to do a jump and then they push off into that plantar flexion, or they're pushing off where they're flicking over that area where there is damage to that articular surface. When they're doing single limb activities, accentuating weight bearing, or they're carrying objects where there's more compressive loading, might be when you hear someone complain. And I think this condition really exemplifies and it's just personally has always been my approach to rehab by understanding anatomically, physiologically what happened to cause the injury, what's going on with the tissues. It almost makes your clinical decision making and progression of patients so much clearer. Because now, if you think about assessing this patient, the idea is compressive forces, disrupted cartilage. That does not make sense for healing. We need to unload that surface. So, conservative management may work. There might be some type of bracing that can help with the offloading, but non weight bearing is really going to be most important. So, this is the patient where we don't want them even, balancing on that foot, using it to stabilize. The imaging that we see here, I had to work this in somewhere. I wish I could see everyone. I know you're shaking your head with me. What what is this doing? Nothing. Um, this is not going to be sufficient stabilization for the patient we're talking about now, or probably anybody ever. But offloading is the key for the osteochondral lesion of the talus. So extend that out into rehab. Well, if we're seeing this patient conservatively while they are, trying to avoid surgery and they're in, a non-weight bearing state, there's still a lot that we can do. Because think of all the soft tissue structures that have tightened down from whatever that initial injury is. We want to do a lot of soft tissue work to ligaments, tendons, capsules to stretch everything, to decompress. We're doing traction mobilizations to offload and get circulation to hopefully have healing occur. Now, this patient can finally weight bear. We think we have the surface that is healing. Well, when we look at moving it, we don't want to put excessive force across, right, that healing part. The anterior lateral is more common, and sometimes if the person plantar flexes all the way down, you could palpate if it's an isolated area of tenderness. It could also be posterior, oh, sorry, anterior lateral. It could be posterior medial. But either way, we don't want a lot of that dorsiplantar flexion, particularly dorsiflexion, to move towards a normal gait cycle. So when we look at initially having this patient move, we're doing shuffling gait for them. We don't want that translation. We are going to have them do retrograde walking so that we're not getting that translation over the foot. They're going to be doing that more backwards walking. We're going to look at sidestepping activities versus forward lunging and weight bearing and reaching and balancing in that sagittal plane. No, we're going to look at more this way to start getting proprioceptive feedback for that patient. Seated BAPS board or rocker board for that patient. So we're not doing as much translation, as great of a range over those healing tissues, and then progressing them up from there. So just a couple of ideas that really kind of, for me, connects that idea of understanding what's happening to us being able to make our intervention specific for the patient. Ankle impingement syndrome is another condition that we might see develop in individuals. It's a little more of an umbrella term that encompasses, just like impingement of the shoulders, something is catching and getting stuck there. It's usually seen about 9 to 12 months after a traumatic ankle injury, often after an ankle sprain. Specifically, anterior ankle impingement is seen in some individuals following that lateral ankle sprain. What happens is the individual, again, we're looking, 9 to 12 months post injury, so we have to distinguish it from chronic ankle instability. But this is your individual when they're in terminal dorsiflexion. So when they go to, if they're doing a deep squat, they're going to have deep seated pain. If they are, stepping up on a stair that's really high, if they're in those deep lunges, they might have that pain, that deep ankle pain, specifically with that terminal dorsiflexion movement. So this is the patient where if you have them do that single limb balance test, they might move in this position where they're having that hip adduction, that knee malalignment. Is it because, again, we need to ask, where is that pain? If they say it's in the front of my ankle, I can't bend down, that's why I'm moving this way, that kind of leads us to believe that something is pinching or getting stuck in there. If we do passive dorsiflexion and eversion, we're also going to see this compromise the patient. What can happen is they may have a little extra soft tissue in there, a ligamentous scarring that has happened, osteophytes could have formed in the area. It could be a little synovial thickening that has occurred um, for that individual. So in that case, with the anterior ankle impingement, we're going to address that soft tissue and alleviating it so then they can get into their range. Posterior ankle impingement is a little bit different. This is going to be an individual, again, where they're getting encroachment in the posterior aspect in the tibiotalar joint posteriorly, but it's for different reasons. This might be an individual who has some different bony anomalies that have occurred that's causing encroachment, particularly when they move into that plantar flexion movement. Something is getting stuck posteriorly. On the far left image here, if you look at this little outpouching here of bone, that is a stedia process that is coming off the talus. Some people just have a little extra piece of bone there that could then be irritating the surrounding tissues. Other individuals, they may have, in this imaging here, they might have ligamentous scarring, extra capsular tissue from an injury that has occurred that's pinching. If we look at this arthroscopic imaging, we can see these frayed edges of a ligament. We can imagine that catching. Another group I want to bring to mind are individuals that have that pain with excessive range of plantar flexion, that have flexor hallucis longus pathology. That tendon passes right along in that region. It's deep to the Achilles tendon, so we need to distinguish this in our Achilles tendinopathy patients. Um, so this is an individual who has from excessive toe flexion or excessive plantar flexion. Maybe there's hypertrophy or irritation of that tendon that has occurred as it passes through that region. So when they go into push off of gait and it stretches that uh, they go into push off of gait. It leads to great toe extension. It stresses that flexor hallucis longus coming here in the posterior ankle. That can create that posterior ankle pain for the patient. So you're going to look at range, excursion. They will also have pain with active toe flexion, resistive flexion of that first metatarsal phalangeal joint. You're likely to see that in an individual who does a lot of that repetitive plantar flexion and with toe flexion. So think of your gymnasts, how they're pointing their toes. Um, Individuals that do more of that type of movement, people who wear high heels a lot, this can also occur in a lot of kicking type of motions, where they go into that plantar flexion. It might occur. So, management for anterior ankle impingement syndrome is going to focus on avoiding whatever activity is aggravating the individual. And some type of boot or shoe that restricts ankle range of motion might be beneficial, because if it's an anterior impingement syndrome, we don't want them to go into too much dorsiflexion. If it's a posterior impingement syndrome, we don't want them to go into too much plantar flexion while those tissues are healing. So that is going to help stabilize the joints as well as take some of the pressure off of the tissues so they can work in controlled movements. If it's anterior impingement, where we want to have them avoid excessive dorsiflexion, maybe some type of heel wedge short term that keeps them in a little more plantar flexion might be beneficial. We want to balance that with not doing it for too long, to the point where the individual then develops tightness of that gastroc soleus complex. It needs to be a balance for that individual. Surgery may be necessary in extreme cases where there are osteophytes or scar tissue that's just encroaching on the space. That might be necessary. Research hasn't really come up with one specific set of interventions or type of bracing or support that is best. It's more having the patient avoid the positions that cause the pathology, and then trying to hone in on, well, is it a bony deformity where the individual has this little extra piece of bone that has to be maybe removed? Is it scar tissue that manually we're unable to work out that might need some surgical debridement of? And then working the patient back into the movements and regaining strength for that individual. As we look at different pathologies that occur of the tendons, we know there have been changes in terminology and our understanding of the different tendon pathologies. The terminology that I'm going over today is based on the International Scientific Tendinopathy Symposium Consensus Statement. And it's great to see that internationally we're coming together, because we all treat patients from so many different countries, and we ourselves are from different areas. So I like to try and present that consensus as often as we can. So what we now know is it's not a tendonitis, it's not a tendinosis, it's a continuum of tendinopathy, that too many demands have been placed on that tendon. It has tried to heal itself, and it may or may not have been successful. So, our first step is that initially there is that reactive phase where there has been, too much stress placed on that tendon, where that healing response is happening, where there's the tendon itself, if we look at it at a microscopic level, it is still homogeneous, it's still our tendon cells, and it's moving towards healing. If it's not successful in that because the body is unable or because the load persists, then it moves into this stage of disrepair. So instead of having those nice type 1 fibers that function really well and can sustain loads, it starts to become more of these type 3 fibers that are healing, that are unable to be truly organized to allow appropriate loading, and there's more discontinuity. Well, that's where our rehab comes in, to try and use appropriate stresses upon it for healing to occur. And that's where eccentric exercise, we find, really becomes helpful in kind of motivating it to heal and align appropriately. If that is unsuccessful, then we move towards this phase of degeneration, where there are more pathological changes, there's actual loss of some of the tendon fibers. But the hope is with rehab, those that are still present, we're able to build their cross sectional area. We're able to get some hypertrophy out of them, increase their adaptability and their capacity so that the individual can still function. That's currently our thought process on tendons and how they're healing and what's going on. What we're going to look at now is specifically related to the Achilles tendon. So, depending on where the individual is in this cascade of events, they're going to present with posterior ankle pain. It can either happen at the insertion of the Achilles tendon down here, close to that calcaneus, or it can be more mid portion, kind of above the 6 centimeter distance here. The reason this occurs can be several. It might be intrinsic, it might just be biomechanically that this individual has that flat foot, that inappropriate alignment. So then the pull of the gastrocsoleus is off during propulsion and gait or different tasks and activities. We take about 10 times our body weight through that tendon. So any biomechanical shift can cause undue load on it. It might be a leg length discrepancy where the legs are different lengths now. So one pronates, and now that shifts the mechanics. There's lack of dorsiflexion range. So translation is different during those terminal phases of the gait cycle, excess demand. Also, some systemic conditions, individuals who have taken certain antibiotics, they seem to target this tendon, make it more brittle, more fragile. In terms of extrinsic factors that contribute, it could just be that overload, just too much work. When they look at training specifically, it is more increasing the pace of the training more so than the volume of training. So it's doing intensity duration too much too fast versus too much overall, where the tissues didn't have time to adapt and repair itself in between. Looking at those training type of errors. Also, I keep going back to volleyball. Sorry, it's one of the few sports I kind of understand. I get what I need for my patients and clients, but from personal. So, for example, looking at training errors, you have those athletes, and I'm in Florida, so volleyball's year round. You're doing indoor during the year on those hard, firm surfaces, reaction times quick. Now you're going to beach in the later spring and summer where there's more of that compliant surface, still expecting to do the same moves. Well, it's not the same because the surface is different. The demands are different on the tissues, places individuals at increased risk of pathology and many different injuries, just to give us an example. So look at our athletes, even our leisure athletes or people with work. They're changing departments, changing surfaces based on the seasons that they're in, right? That grass those delivery drivers are going across is different than the sidewalk in the winter, etc. Things to think about as we look at rehab from these different conditions. Clinical presentation, you might be able to palpate some of that localized thickening. Here's insertional here. The palpation test is again where you're going to palpate that tendon and it would be painful. Arc sign, this is going to help you distinguish Achilles tendinopathy from other adjacent swelling. So if you palpate that area of edema and the individual dorsi and plantar flexes, if it moves with the tendon, then it more leads us to believe it's related to the tendon. If it stays still, then we might think it's different structures in the area. Looking at endurance of our ankle plantar flexors, we would be doing this on a level surface. I just like the picture otherwise. The idea is we're going to have the individual do their heel raises. We're going to count how many they're able to perform to look at the endurance of that muscle group, comparing it to the other side. Some resources say that around 28 is normal to be able to perform. Other resources say somewhere between 22 and 24. Others say compare it to the other side. Either way, we do want to look at the endurance of that muscle group compared to the other side. as we look at rehab, alignment of that foot is important for the Achilles tendinopathy. So we're going to maybe look at utilizing some type of arch support to restore that arch for the individual. We're not using a night splint for this pathology. We're looking at that gastroc soleus regaining the range of motion of those muscles. Body weight resistance exercise is what is recommended. We'll look at the eccentric protocols that are recommended. And then when we look at modifiable risk factor education, body weight is something significant to consider that changes in body weight change the demand and how much the body the gastrocnemius has to propel through the gait cycle. We want to come further up the chain for these patients because the demand on that gastroc soleus to propel through the gait cycle is going to be related to the positioning that you're in. So we need to make sure the individual has 10 degrees of hip extension, that they have that 65 degrees of metatarsal phalangeal extension, that they can control internal rotation and adduction of the hip and the entire lower extremity. So really important with this pathology to look up the chain to make sure everything's coming together to put the appropriate demand on that gastroc soleus for gait. In terms of the exercises, I have no doubt everyone's doing this. You just might be calling it something different. So the Alfredson eccentric loading protocol is looking at having the patient, like in the right image here, they're going to use their uninvolved extremity to rise up on the step. They're going to switch to their involved extremity, eccentrically lower down, and then flip back. The goal is for the individual to do 3 sets of 15 with the knee extended and then the knee flexed to about 45 degrees. 3 15s of each every day, twice a day, which leads us to 180 reps. If we lead with that, we know what's going to happen with our patients, so we don't. Research has actually shown that even if they don't reach that 3 15s of each, that there are still significant benefits, and that will be the goal to work towards for the individual. 7 days a week, usually over 12 weeks, leads to positive outcomes. The Bayer program, this is looking at heavy load, slow resistance. So again, the idea that this mechanical loading is promoting healing of the tissues, or it's building the capacity of the tissues that are remaining to get adaptation in the fibrils that are still there, as opposed to new fibril formation. We're starting our patient, we're doing 3 specific exercises. So we're doing the heel raise with some type of resistance in sitting, and you can add a board or wedge to get more range of motion. We're going to do standing barbell heel rises, and then we're also going to do the leg press with knee extension. The goal is to do 70 to 85, working up to 85% of the 1 rep max. And again, doing our 3 times 15 repetitions. This is concentric and eccentric. Seaver's disease is a condition that occurs in children 10 to 14 years old, and the location and the pain may be very similar to these Achilles tendinopathy. Seaver's disease is looking right here at the fact that this little posterior portion where the growth plate is on the edge of that calcaneus is right where the Achilles tendon inserts. So if it's called the calcaneal apophysitis, so the apophyseal is where that attachment is of the growth plate. Um, and again, if we squeeze that, it would be painful. It's kids who are doing a lot of kicking, jumping, running type of activities where the bone is growing faster than the muscle has time to elongate. So it creates that excess pull and irritation at that site. It tends to be self limiting. The key is trying to get the child to back off of the exercise in the meantime. So, a heel lift might help because it'll put them in a little more plantar flexion. So, it shortens that tendon a little bit. So, hopefully, as you're stretching and they're growing, things will have time to catch up. We have to watch the shear stress and repetitive loading that's occurring. And again, it's going to be self limiting in terms of kinesiotaping to help this. There's really conflicting research. The muscle length has to catch up with the bone growth. It is really what needs to happen. So good cushioning is important, good stretching for the individual, and then again finding a way to have them rest it so that inflammation can heal and that growth plate can heal while the muscles stretch them back out. Achilles rupture is a different condition. So this is where rupture of the tendon, it's not a slice. It's more of, a rope that's fraying. So this can occur for several different regions. It can be, high load dorsiflexion where they just feel that give way, like they got kicked in the back of the knee and it gave way. Is acute. Spontaneous is more when there's degeneration that has occurred as a progression from that Achilles tendinopathy that we've discussed, or individuals who have other systemic conditions, excessive use of steroids, certain antibiotics. Those would tend to be a little more bilateral. Um, so what they're going to look at is based on how many of the fibers are disrupted, can we manage this conservatively or is surgical intervention necessary? Today, we're focusing more on that conservative intervention. So, you might be able to actually palpate a gap in that tendon. The tests, provocative tests that you're more likely to use are going to be your Thompson test, where you're going to squeeze in on that calf. And if we have an intact tendon, we would expect, plantar flexion of that foot would be normal. It's positive if that doesn't happen. The Matley's test is when you have the patient prone with both of their knees flexed, we would expect, as in the back leg here, for there to be a little bit of plantar flexion. The front leg here, where they're dropped down into dorsiflexion, that's because we're having giving way here of that tendon. Rehab for these patients, as with many of the patients that we discussed today, we're looking at DVT prophylaxis is going to be part of rehab, which can be elevation, compression. Maybe the physician's prescribing something, but because they're not doing a lot of those ankle pumps, we do want to move the toes if we can. We do want to keep the knee and the hip moving because if the circulation is going down, it's got to come back up. Keep that in mind. Looking at functional rehab, the idea is, like we talked about with the ankle sprain, to allow movement, but not overdo it to where we're compromising the healing that's trying to occur. So, what they may be looking at doing is having the individual in a boot, and then they place a wedge in that boot that starts out high. Maybe it's more of a 30-degree wedge. So you're getting approximation of that tendon edges. And then over the weeks, it's slowly lowered down as that tendon's lengthening and healing. So we're not doing just complete immobilization for these patients. We're looking at doing more management conservatively. There are some guidelines from the American College of Occupational Environmental Medicine saying that conservative management using that wedge and then controlled therapy to encourage movement and strengthening as healing's occurring is more beneficial, because a lot of times surgical interventions lead to wound dehiscence, infections, things of that nature, greater stiffness. But on the flip side, they're saying with some of this conservative management that it may place the individual at a risk of re injury. So, rehab's going to be patient specific in that respect. Looking at our other tendons on our lateral complex, we're looking at our peroneal tendinopathy. This again is looking at those peroneal tendons coming down that lateral complex of the leg. We already talked about there might be overstuffing. If you're lucky enough to have those extra tendons in there, you increase your activity, could be a component. Someone who has a hind foot in more of a varus position is going to place greater stress across that area, as well as those individuals who have ankle instability, more of that like supinated type of foot. Looking at footwear where our peroneal muscles have to work harder, performing more inversion to keep the person stabilized. This could be that individual if they're in a sport where they're using a skate that or a boot as part of their skiing, hockey, things, figure skating, where it's not tight enough, not stabilizing them, the muscles may have to work more. That could be a challenge. Looking at individuals, even they go buy the sneaker that looks nice. Well, if it's made for a pronated foot, so it supinates you, and now it's pushing you in the wrong position, or you have a supinated foot to begin with and it supinates you more, it is pushing you in the wrong way because now those muscles have to work through a bigger excursion. Placing more demand on them can lead to that trauma. Or if someone is just working in a job where they're on a slippery surface, where they're on different types of inclines that may cause them to have to use their peroneals more, this can lead to increased risk. So, what we're going to find is pain with that eversion, pain with plantar flexion for these individuals. It's going to be exacerbated in those circumstances we just discussed, where they have to work harder to balance on that ankle. So our rehab is going to look, do they have stability they need? Had to fit these shoes in somewhere. um, this is an individual. I know we can't always go by the shoes, but it really shows us someone whose peroneals are not functioning. They are, going too much into supination. So this might be someone who needs an orthotic in order to realign that foot to allow those peroneals to not have to work through such a significant range of motion in order to stabilize. So they might need some type of lateral wedge. So if the individual is more supinated here, if we do a lateral wedge pushing them back up, now we've realigned that foot, taken the stress off these peroneals. And then we would strengthen them in those corresponding ranges of motion. Plantar fasciitis is a condition we know that has that classic first steps in the morning plantar foot pain. This all relates to that windlass mechanism. And if you haven't heard a name of it, I don't think I learned it back in school, but you know the mechanism, even if you're not familiar with the name. The idea is that as we progress through the gait cycle, that we have this plantar fascia that runs from the metatarsal heads down to the calcaneus, that as we translate over and we get extension of the first, there we go, metatarsal phalangeal joint, that plantar fascia pulls on its attachment, shortening, and it raises the arch of our foot. So now we have a nice rigid lever to push through gait. So that's this great toe extension, tightening of the plantar fascia, raising the arch for a nice rigid lever for propulsion. That's what's supposed to happen. Unfortunately, on the bottom image here, if someone has that excessively pronated foot, that mechanism is already overstretched and it can't. Then even the great toe extension isn't enough for it to pull that navicular back up to create that rigid lever for gait. So now those nice long fibers, like in the image here on the top left of the plantar fascia that run longitudinally, kind of parallel to each other, that are made to accept those longitudinal loads, suddenly they have all these compressive vertical loads coming down on them and they can't take it. So that's when they create that damage to them. That's where we're going to get this classic pain. If we do that medial calcaneal tubercle, we'll have that point tenderness in this area for that individual. The windlass test you can utilize. This can be done in weight bearing as well as non weight bearing. You're going to have the individual on the surface. You're going to perform that metatarsophalangeal extension of the great toe, and then it will likely replicate that pain for the individual because you're engaging that plantar fascia that is irritated. We do need to consider the pain that the individual has as we are palpating in the area. We're going to look at ruling out other proximal pathology, nerve entrapment, radiating pain if it's coming from the back for the individual. If they have generalized swelling of that calcaneus, we're thinking, and the positive squeeze test, then we're leaning more towards calcaneal fracture, and they would probably have a history of more specific trauma for that individual. If we end up going more posterior on the calcaneus and there's pain, then we're going down that path of looking at Achilles tendinopathy. Maybe we're looking at posterior impingement. If it is the flexor hallucis longus tendon. So just to give you an idea of your differential diagnosis here. Our rehab for patients with plantar fasciitis, the idea is to restore alignment of that windlass mechanism. So they might need some type of arch support or cushioning for them. Night splints may be utilized because as the individual is sleeping at night, the toes flex down, that plantar fascia shortens. Then when you take those first steps in the morning, it creates more of that vertical force excessively and irritates them. That might only be for a week or two to give a little bit of relief. That would be like this image here. There are different kinds. The key is having the individual stretch that fascia out before they take those first steps in the morning, either with a manual massage. We may tell the patient, put a ball and roll your foot on it before you get out of bed. Bear in mind, we need to, again, look at their follow through. The patient may not tell us that my feet don't even reach the floor when I'm sitting on my bed because it's so high. Um, so we may need to teach them more of a manual technique. The research is showing that using foam rollers is really beneficial for individuals with plantar fasciitis, that in order for tissues to really elongate, it's a complex mechanism of satellite cellular activity that has to happen, that we have to stretch the tissues to a point just below the individual's pain threshold. And what they're finding is if they're using a foam roller to stretch, either between the compression of it, if you're using, like the half moon wedge or an actual foam roller, the friction of it, they're finding that the pressure receptors being stimulated allow the individual to take a greater stretch and put more body weight into it to reach that threshold where actual tissue elongation can occur for better carryover. So foam roller stretching is and weight bearing stretching for plantar fasciitis is showing much more beneficial. Also, BMI, any body weight reduction. There's been research with individuals who have undergone bariatric surgery, and they have found that in just this one cohort, I want to say their BMI went from 45 to 35, which is significant. 90% had resolution of their plantar fasciitis. Now, a lot of plantar fasciitis, the research says, is kind of self-limiting anyway in about a year. But we know during that year there can be a lot of adaptations and trauma that occurs to other joints. In your populations that you want to look at related to plantar fascia, to be preventative. Anyone who carries excess loads, I've done a lot of education in healthcare for other disciplines. For example, cardiovascular technologists or x ray technicians that are wearing heavy lead, even anyone in the OR. That excess weight is more vertical compressive force on the plantar fascia, and that exacerbates plantar fasciitis or can lead to the development of it. So teaching stretching programs to utilize during the day, a wall stretch, or if someone needs to be on more of a surface that is a shock absorber. So think of different work settings where you might need some adaptation, either during rehab as the patient's recovering, where they're just weight shifting, putting their foot up sometime, anti-vibration surfaces, things like that. Turf toe is the final diagnosis that we will take a look at. This is a hyperextension injury that is occurring. The pain and location of this is going to be right about in here at that first metatarsal phalangeal joint. It occurs when, think of if you're looking at this soccer player, how they are plantar flexed and the toe is an extension, and then their body weight is a force coming down, it's going to stress the ligaments, the little fibrocartilaginous structure in that joint. um, they say like the football player at the bottom of the stack, or someone who's doing a push off type of activity, where that toe is jammed down. It's called turf toe because the turf is not forgiving. So it kind of jams the toe in place, where we have in pain created and trauma in that area. So passive extension, active flexion of the first metatarsal phalangeal joint is going to cause pain for that individual. Lockman's test is the assessment tool that you'll utilize. You're going to do that compressive test, similar to we do at the knee, looking at the meniscus, but we'll do it here. So again, important to note the joints we're doing the different tests at, for the individual. Rehab in this case, based on the grade of involvement, may just be some type of taping to avoid going into that hyperextension. And there are different types of tape that can be utilized. If you haven't seen it before, the idea is that we want to avoid during the terminal phase of gait, stance phase in that push off, we want to limit that metatarsophalangeal extension. So this type of taping is going to go around the great toe and then come down the foot, so that is going to limit that movement a little bit as the individual's healing. Grade 3 might need surgery. So the idea in terms of the activities that you can perform, we can go into plantar flexion passively to start because we want to keep the motion there. Then we're starting low impact activities. So we're working more into plantar flexion and slowly into the extension. So even when you have that patient sitting doing a BAPS or a rocker board, or just sitting with their foot on the floor doing reaching, you want to make sure that their heel isn't rising, because then you're getting metatarsophalangeal extension that they may not be ready for yet. So you need to look at the length of that gastroc soleus also. As you work into rehab, then you're going to work into activities where they're doing active plantar flexion, active extension, and even just the body weight transition into the push off phase of gait. So I put this individual on an incline. I'm in Southern Florida. We don't really have that here, but think of a work ramp going up or down it. Maybe they need to be going sideways down that ramp, or some other safe alternative, because this is going to create a lot more extension. Think about if they're working on sand or more of a compliant surface, do they need a shoe that's a little bit more rigid in that meantime? If we're looking at going back to sports, make sure that cleat is tight enough and the right stiffness. It's not too loose for that individual. So that finishes our specific diagnoses. What we're going to look at now are a couple of different assessment tools that we can utilize to gain information about how our patients are presenting as well as progressing. First one, our patient reported outcomes measurement tool, the PROMIS system, looks at pain interference. So, how is pain impacting the individual's ability to function? While this tool is not disease specific to the foot and ankle, it has been researched and been found to be sensitive and responsive to foot and ankle pathologies. And actually, they found looking at pre-op cases that it's better than the visual analog scale at giving information in terms of outcomes. So it's going to have the individual look at a period of 7 days and recall. How their foot and ankle has impacted the function in their life. It's going to look at not only our basic physical activities and recreational, looks pulls in the emotional and social components, and also sleep and enjoyment of life. So this is a nice tool where you'll get a lot of information to help guide your interventions in many different aspects. Maybe for the sleep, do you just need to look at positioning? If it's that patient with plantar fasciitis, maybe you just need to teach them to maybe sleeping on their side would be beneficial, or that couple weeks of the night split would be helpful for them. There's also a pediatric version, and then also there is a parent proxy version where the parent can answer it for the child. So it might actually be interesting to use a combination of those, or even for your patients who are unable to communicate as well themselves, using a proxy version also. The lower extremity functional scale, this tool is more specific to the lower extremity based on its name. It's going to look at specific everyday activities that range from more basic, like sitting, to little more functional, such as squatting, and then going all the way up to running. What they find here, looking at it relative to patients with different foot and ankle pathologies, that the minimal detectable change, that means what point value movement does there need to be for it to be a true change, hopefully improvement for your patients. For ankle sprain, for example, they're finding that a 4 point change is actually specific enough. um, this particular tool is validated longitudinally for patients with different foot and ankle pathologies. So it can, again, give you some information to help where your patient's at and direct your interventions. The foot and ankle ability measure. This tool is going to look at our ADL activities and our sports. So you can create two different sub scales where the individual's rating their different activities from a scale of I have no difficulty doing that to I am completely unable to perform this. And then it does give the option of saying it's not attributed to the ankle, which I like that piece, to have another idea of information of where to look up or down the chain, and put it together, especially if you're looking at a patient where it might not be a foot and ankle pathology to start with, where maybe the compensation has led to the foot and ankle pathology. It may help tease things out for them. The minimal clinically important difference, meaning a change that actually means we have truly, hopefully, made an improvement on the ADL score, is 12, and then on sports would be 9. The identification of functional ankle instability. Now we're looking at our patients who present with that chronic ankle instability. This is a relatively new tool that I think it was 2013 or 14, that it was first put out there. It is trying to look at catching those patients that have that functional instability of the ankle where they have that kinesiophobia. So this tool gives a specific definition of what that feeling of giving way is, so the individual can keep reflecting back to that as they're answering their questions to hopefully give them a little more specificity in their answers. They have found in some research studies that 88% of individuals who met the criteria for chronic ankle instability were actually identified through this tool. So, in terms of the max score, it's 37, and then greater than 11 suggests that chronic ankle instability to give you an idea. The Cumberland ankle instability, this is another tool that's looking at that patient with the chronic ankle instability, but the focus here more is to separate out functional instability from more of an anatomical instability. So we're looking at saying, well, is there something where anatomically something's off, or is it more that patient where proprioceptively needs to be our focus? So it's looking more at that functional instability of the ankle. Originally, they said a cutoff score of 27 identified those patients. Now they're saying that a score of 25. So somewhere in between there. This test is going to, or tool, I should say, is going to ask the patients things like, when I move in a sharp change of direction, my ankle feels unstable, or I am able to stop quickly and my ankle feels stable. So it's going to be pretty specific for our individuals. And again, that may help direct us in terms of how complex to start with our balance and our functional challenges for them. The Victorian Institute of Sport Assessment Achilles. So, this is looking at our patients with Achilles tendinopathy. It looks at pain, function, sport participation for the individuals, specifically to that Achilles tendon. Um, the score that we're seeing, maximum score, is 100. So if it's lower, the individual is going to present with greater symptoms of the condition. The JOSPT had done a study utilizing this tool, and they looked at individuals who received injections for their Achilles tendinopathy versus those who just performed an exercise program. And they did find that a score change of 14 points, so a change of 14 points, hopefully improvement in that value over a 12-week period, um, did show that the interventions were moving in a positive direction. So a change of 14 over a period of 12 weeks was showing that you were moving in a positive direction with your rehab. The clinical test of sensory interaction of balance is another tool that we can utilize in order to gain specific information on balance for our patient. And this is another one. I have no doubt everyone's doing this. You just might not be calling it this or using the specific pieces of equipment. This is looking at, we need to challenge our patients eyes open, eyes closed, level surface, compliance surfaces to really target all those different aspects of our balance systems and our different contributors. The true test uses that visual conflict dome, which uses a Chinese lantern that you put these pieces of tape down to create different visual challenges. And then you're going to have the patient stand under all these different conditions and combinations of and time, how long are they able to stand. So if you perform the true test in the kind of documented way, you end up with a total of 540 seconds that the individual would max be able to balance, be stable. So, that's looking at the combination eyes open but level surface, eyes closed but uneven surface, and kind of mixing and matching. So if you look at that as the total, less than 260 seconds is that individual who is more likely to be at risk for falling. The star whiskers and balance test. This is where you're going to put those pieces of tape out at those 45-degree angles and ask the individual to step in different regions to look at their balance. You can either look at the distance they go. There's a way to calculate it based on how long someone's leg is and look at positioning. Consider as you're doing these tests, do it with dual tasking, motor as well as cognitive, to really make sure that person is truly able to balance. To give you an example, someone who has a lateral ankle instability, when this person is reaching back their leg posterior medial of their uninvolved leg, so forcing them to balance on this involved leg, that's going to cause them to utilize those peroneals more, cause that lateral complex to kick in a little bit more. So for chronic ankle instability, lateral ankle instability, that movement is going to give you a little more feedback. You can also look for dynamic symmetry compared to the other leg, compared to reaching in different directions. A slimmed down version of this test is the Y balance test. So this is kind of a fancy version where it has these little plates that the individual pushes forward, pushes back in the different directions to see how far they can go. And again, if you're asking the person to push forward, I should go this way, push forward. Um, we can see on this back leg, we're getting more dorsiflexion. So that person who has anterior impingement is going to likely have more difficulty with that component of the test. So this again, these different tools we can look at to help us hone in on our diagnoses for our patient and then set appropriate goals and have measures to give us that objective information. And then lastly, looking at our single limb hopping tests. These are important. We're going to compare it to the contralateral side for the individual. We have the individual single limb just do that one hop forward, see how far they're able to go, triple hop, see how far they're able to get, and then the diagonal hopping. So those are all distance measured versus our timed measure, 6 meters. How long does it take for them to do a series of forward hops in order to achieve that? To give you an example of different values for this test versus just comparing to the other side, for Achilles tendinopathy, one particular study examined it and they said that if they achieve 90% of the value of the uninvolved side, that was acceptable symmetry. Other research said as long as you achieved 85% of the contralateral side, that was acceptable. So there are different ways that you can look at your values here. Just know that you don't always expect it to be 100% because even if you took a healthy individual, they probably wouldn't be 100% comparing both sides. In conclusion, we've taken some time today to look at all of the Several, I should say, different pathologies that involve the foot and ankle, examining the different assessment of them, mechanism of injury, which lead us to our key focuses in rehab for that population so that we can best enhance the outcomes for our patients.